live.
Good evening. Welcome to the second episode of our month-long e-conclave on breast cancer, brought to you by the IHW Council and Novartis India. Women are the glue that keep our families together. Behind every happy family is a healthy woman. From taking care of household matters to earning their livelihoods to taking care of the family, women pack in more than 24 hours of work in a single day. It's not surprising that their own health and well-being is the last thing on their mind. Breast cancer is the biggest cancer killer among women in India when it comes to cancer cases. Breast cancer accounts for 1/4 of all cancers in Indian women, but half of all cancer-related deaths. Now, here's a quick recap of the inaugural session of the Breast Cancer Action Month addressing India's breast cancer epidemic, moving from awareness to action. We kick-started a month-long campaign 2 days back. Here's an excerpt from our first show.
Breast cancer can certainly be given the title of Queen Regnant. Yes, this crowning will not be an over-embellishment, as breast cancer is the #1 type of cancer in women today. To exhort and encourage all of us to move from awareness to action, to spot and stop breast cancers, ISW Council in partnership with Novartis India embark on month-long mega virtual conclave, Breast Cancer Action Month.
And we like to use a South African phrase which says, Sabi, Sabi. Fear, fear. You don't have to fear anything else. Get rid of the fear and you will then arrive at a point where you're willing to notice, to look, and to listen to your body. So awareness is something that is very, very basic.
Every opportunity of health checkup in the aware people who want to take care of themselves should be given the opportunity of doing a mammography, and that will pick up the breast cancer before it manifests, and that's almost a guarantee of curing that patient with minimal intervention. So that should be encouraged more and more.
So whatever awareness sessions we take, whatever campaigns we do, whatever we are doing in this regard has to be around positivity and the good parts of being diagnosed early.
The science and the research has evolved, in such a manner that there are effective treatments now available also when the disease has spread to other bodies, what we call it as a metastatic, disease. So there are innovative drugs, which has now shown that it also increases, life. So positivity, awareness, inertia, somehow we need to overcome so that we seek help early.
You teach one woman and you tell her, you teach all the women in your family, your mother, your sister, your grandmother, and be behind everybody. So one lady teaches 10 lady and that will start spreading. So we tell them that the breast self-examination, see the video, be oriented with it, nothing to worry.
What we can understand that as far as the breast cancer issue is concerned, the power lies within us. With the message that, Pink will lead to action, mobilize our collective will to act against breast cancer. Thank you so much.
The mortality rates is disproportionately higher. This can partly be explained by the large percentage of late-stage detection and treatment of breast cancer in India. Now, the prevalence of breast cancer is more in cities than in rural areas in India, but the mortality to incidence ratio was found to be pretty high, as much as 66 in rural India compared to just 8 in urban registries. Besides, Most of the treatment facilities are located in cities, which makes the breast cancer patients spend extra for transport, stay, and treatment. Today, we are going to be joined by a panel of experts who will discuss if breast cancer is largely an urban phenomena and also come up with ideas to transform awareness into action at all levels, from our villages to cities. Please join me in welcoming our esteemed panelists. We are delighted to have with us Dr. Neelakshi Mahanta, Associate Professor, Head of Department of Medical Oncology, Cancer State Institute, Guwahati Medical College. We have Dr. Kishore Singh, Director, Professor, Radiation Oncology at Market Access and Alliance Management at Novartis Oncology, India. And we have Dr. Prashant Mathur, Director, National Center for Disease Informatics and Research, ICMR, who's also with us during this discussion. We are also awaiting for Ms. Amritah Sandhu, Director and Co-founder of CareIndia, to join us shortly on this discussion. I would like to welcome all our panelists to this special discussion. Thank you so much for joining us today. We really need as much action, as much voices as we can get, so that everybody listens and make sure that their wife, their mother, their sister, their daughters, they are aware of breast cancer and save themselves from this disease by proactive action. Now, let me start first by taking opening remarks from each of you on what are your thoughts on the divide in the incidence of breast cancer in urban versus rural setting. So I'll start with you, Dr. Prashant. What in your findings has been the experience, and how does this? You have particular data. What is the reason behind that? I would like to start with you, Dr. Prashant.
Yes, good evening, and thank you, Anisha, and the Council for organizing this very wonderful and needful activity, a month-long e-conclave on breast cancer awareness. Our institute, the National Center for Disease Informatics and Research at Bangalore, we run the National Cancer Registry Program since 1981. And we are the largest authentic source of data of cancer for all sites in the country. We have just released our report in August, the 2020 NCRP report, based on 86 cancer registries spread out across the country. And let me tell you that India ranks third amongst the world when it comes to breast cancer. We are second to US and China. And we see a lot of mortality and deaths because of cancer, of breast cancer. Somewhere around 2003 and 4, till before that, cervical cancer was a leading cause of cancer in women. However, sometime around 2003 and 4, the switchover happened and breast cancer started picking up. And we now have breast cancer as a leading cancer amongst women. But it fights for number 1 and 2 positions in most of the registries. So we should not forget cervical cancer as a major cancer in women. The registry report has very clearly shown the gradient across big metros. When you name Hyderabad leads the country with 48 cases, new cases per 100,000 population, and then led by Chennai, Bangalore, Delhi. And as you go down, and India is a heterogeneous country, so from 48 we have the lowest at 7 in Meghalaya. So you see a 7 times difference happening. And you can see that from big metros, it moves to cities, big cities, to towns and to villages. But let me assure you and tell you that it is not that it is absent in rural areas. It's only that the burden is higher in the urban areas. If you look at our registry report, about 12 per 100,000 women in rural areas have breast cancer, and 3 times this in urban areas. So there are still, it's a cautious approach we should take, so that it's an opportunity and it's a challenge. The opportunity is to keep the rural and the smaller towns intact and do not bear the onslaught of breast cancer. whereas those who are suffering from breast cancer in big metros, they should be treated adequately.
Right. Dr. Kishore, what is your experience? You head the radiation oncology in Nayak Hospital. How much of your patients are local city dwellers, and how many are traveling from outside cities for treatment? What kind of distribution do you see?
Good evening. And first of all, this is very timely broadcast done by you to increase the awareness. This is very much required. As far as Nayak Hospital, Manoj Medical College is concerned, we are receiving in roughly about 40% from outside the Delhi. Main reason is the nearby UP and Bihar cancer facilities are hardly existing. In future, it may change. Other thing is we are providing totally free of the cost, all the costly medicine, radiotherapy, etc. So poor people are coming to us. So demography about the breast cancer we get from the lower state of the society. But still, among women, breast is the number one. Majority of the cases, about 1/5 of the cases are breast cancer cases. Only difference is persons from urban background are having early stage disease, and those coming from rural are having advanced stage disease. They take time to reach Delhi and they take time to get it diagnosed. Over the year, stage is also getting early with each passing year.
All right. So, the awareness campaigns seem to be working. Dr. Mahanta, Dr. Prashant told us that in a state like the center, the data collection center in Meghalaya, the number posted is very little. Now, the truth is that most of the cancer facilities are actually, cancer treatment facilities are actually in Western and Southern India. And no wonder you see so many more cases in these places, because that's where you get the treatment. So, in your practice, do you see this disparity? Do you see your own local community having to travel far for treatment?
Thank you so much, Anisha, for that question. And I once again thank IHW Council for this wonderful platform, which is the need of the hour today in our country. We really need to bring this conversation to the table. And coming to your question about, most of the centers that we are seeing for treatment, our multimodality cancer centers are definitely located in the metros. In fact, in the northeastern region, in the state of Meghalaya, there is the Northeastern Indira Gandhi Institute of Regional Medical Sciences, which has an oncology department. And in Guwahati, we have a central government institute, that's the B. Barua Cancer Institute, and the State Cancer Institute, which is where I work, which is just in its infancy stage. We are almost just around 4 years old, but we are seeing a huge footfall of patients because we are a government institute. So today, I can vouch that a large number of patients who are actually moving out of the state for treatment are actually now coming to our doorsteps. And that is the reason why we are catering to volumes as large as, almost 8,000 patients in a year. That's what we have been seeing in the last 3 years. And we are in the 4th year running. And we have one private center in Guwahati, which is a private cancer hospital. So having said that, we are... being a government institute, we are also getting a large burden of the rural population who are coming to our doorsteps. And we are also giving the best of the standard of care as per international protocols, as per guidelines, free of cost to our patients. So needless to say, we have a huge number of rural population who flock to our hospitals, and the people who can pay, or maybe those who are from the urban lot, they may step into our hospital, but would rather, take a route to one of the metros, and then they would, try their hands in some of the hospitals outside, and maybe they would be referred back to us for continuation of some of their treatment here. So the rural percentage was 54%, and 48% we got from the urban areas, which itself is actually quite a big chunk. So I would say this shift towards the urban population, definitely in the past few years, we are seeing a tendency of more younger people, younger women getting cancer, breast cancer, that's below age of 40, and also more from the urban classes. This is definitely a trend as per the ICMR data also, as Dr. Mathur has pointed out.
Right. Ms. Vandana Gupta, I'd like to come to you. You're doing such great work with those who are suffering from cancer. They reach out to you. What is your experience when it comes to those living in smaller towns, in villages? Do they reach out to you? And have you been able to understand why do they present themselves for treatment when it's really very late?
So, good evening. I'm sure everybody has a lot of data to say what they're saying, but my personal experience is that though there a number of cases in the urban areas are more because of the awareness, because of like no ties on the stigma and all that, but in the villages the cancer goes undetected, according to me. And it's always late presentation which happens because the woman in the house is scared to talk about it. Nobody bothers about her life. And like you mentioned earlier that, the woman is the fulcrum of the house, but at the same time, her health is not priority. So, and then, often I've heard this myself from a patient saying that, I don't want to get a mastectomy done, and she was from the rural area because my mother-in-law has told me that she will not keep me in the house and she will get her son married to somebody else who's a full woman. She didn't want a half woman to be there because after the breasts were removed, she would be no good. She would be as good as, like being no good as a woman. So I think because of the lack of awareness, because of the lack of fear, because of the stigma which is attached to the disease, many people in the villages and the rural areas are not even going to the treatment centers to get themselves checked up. And there's no, we may talk about a lot of early detection programs happening in those areas, but I really am not sure after hearing those programs how many people are really responding to it. Which is happening more in the urban areas, which is a very good thing because at least we are able to control the numbers in the urban areas. But I think the divide is more because of all other factors than actually, the cancer being less. It may be less because of the diet, because of the type of exercises that the women do in the villages. All that may add up to it being less. But however, I always feel that, we are missing out a lot of patients because of their being in the rural areas and also because of the stigma which is attached to the disease. Do the doctors say now the stigma is not there? I'm not so sure about it.
This is really heartening to hear, ma'am, that how a family can think that there's a stigma attached to a treatment that a woman can undergo. Mr. Kumar, your company offers cutting-edge drugs and treatment for, breast cancer, but you must also be doing your awareness campaigns to make sure that women are aware that what cancer symptoms are like. What has been your experience, if you have had any, in tier 1, tier 2 cities? Are women upfront? Are they afraid? What are their main concerns?
Yeah. Thanks, Anisha, for the question. And before I start, I would like to thank ICMR Council for setting up this expert panel discussion. And the fact that we are debating the question whether breast cancer is an urban problem itself means that there's a lot more that we need to understand of the issue, right? As Dr. Prashant Mathur pointed out, the amount of data we need to capture on this is much more than what we have right now. And I would like to take two analogies to explain what I think is how we need to approach it. The first I would say is that we might be sitting on a Titanic and the breast cancer problem in India might be an iceberg. What we're seeing above the water is just what we're getting to see, which is the urban issue. But there's a lot more cases like the iceberg, which is more submerged in the water, a lot more cases in rural areas which may not be getting identified, right? And the second analogy I might like to take is about the way we are tackling the latest health epidemic, COVID. The more you test, the more you get to know. And the better your treatments, the better the outcomes for patients. So the better we are able to improve the health systems in rural areas and bring care to patients in tier 2 and rural areas will be better for the general population and better for outcomes for breast cancer that we have in the country.
Right. Dr. Prashant, you mentioned about, the data being collected in the centers. And, compared to 15, 20 years ago, now more centers have come up in different areas of our country. Now, despite the collection of the data and perhaps greater awareness of this problem, are healthcare facilities enough for treatment on a decentralized basis? Because people are still going to have to travel to cities as of now situation. Dr. Mahanta has told us about her center, which she says is infancy. It's just 4 years old. So where do people in the Northeast go? They have to travel long distances. So, what Mr. Kumar is saying, that you create the awareness, even if you create it at the bottom of the rung in every village, in every district. Some people think, oh my God, I can't go so far away. Where's the money? I don't have the money. How will I ever seek treatment? Forget about it. Do you think this happens because, care is so far away and, treatment costs are things that people also have to factor in?
Yes, it does happen, but let's keep Northeast as a separate discussion point because of the various geographic localities. Also, that the treatment facilities are not there, but it is picking up very fast. Even the institution where Dr. Neelakshi is there, and there are many other institutions. So the Ministry of Health is ramping up tertiary care hospitals in the country. Under the various regional cancer center and tertiary cancer hospitals being set up, and they are coming up quite well and rapidly, even in the Northeast. But yes, a lot of people, almost we have estimated 60 to 70% of cancer patients from Northeast move outside Northeast to seek treatment. Now, while there is a deficit of cancer treatment centers, the problem is that most of the cancers, even in our registry report, if you look at it, 57% of cancers when they are diagnosed are locally advanced stage. We get hardly 25% of cancers, breast cancers, which are localized. Localized cancers are amenable to surgical treatment, and good surgeons are available in many other medical colleges spread out across the country and other good hospitals. It can be tackled there. When you talk about chemotherapy, they can be given there. So there is a national program for prevention and control of cancer, diabetes, stroke, and cardiovascular diseases, which is providing district level care. The issue becomes complicated when you have advanced cancer, and then they have to be handled at a better center, which is armed with multimodality treatments, including radiotherapy and those kind of things. So the focus should be to get them early, so that local remedies and local solutions can be offered to them. And now Ayushman Bharat is there. So, a lot of people will be beneficiaries, so they will be taken care of. And there are a lot of state governments as well as central governments and other organizations who provide that kind of a fund relief for cancer patients. In fact, cancer is one of the diseases for which there is a lot of support in terms of incentivization and reimbursements happening. The barrier is the desire to move ahead for treatment, as was explained by one of our learned speakers. Once we overcome that barrier, many things can be tackled.
All right. So let's come to you, Anna ma'am. How will you overcome this barrier? You're saying we create awareness, but even women are not coming forward. What is the way out then? I mean, if you're going to wait this long, then you're going to have problems going far away and things like that. So how do you overcome the stigma?
Okay, what I would like to say, first of all, apologies for anything that I may say which is not palatable. But, we deal with a lot of patients, and we know that we've been recommending them to use the Ayushman card if they have the card. But very little is known about it in the villages, in the rural areas where the need is a lot. And I know of patients traveling more than 700 kilometers to go to a center to reach a Ayushman Bharat clinic, and then they are refused because they can't be given. Though they have the card, they have all the relevant papers. So there has to be some sort of a transparency and clarity on the Ayushman Bharat thing. The second thing is, I always believe that in the rural areas, we may go and say whatever we like to say, but unless we involve the panch, the sarpanch, or the Asha workers, who can be trained and explain the usefulness of these tests and why it is mandatory. And instead of asking them all to come to a bigger center to get the checkups done, if we can help in making provisions over there, and why go into for mammography? Teach them breast self-examination, which is an easier way of doing things. They can do it in the privacy of their rooms, in their houses. And only if they have been able to find that there is something which needs to go for a mammogram, then they need to come to a city. Also, I think that our doctors who are there are very good, but maybe they miss out on explaining about the various symptoms of breast cancer, to the patients. So even having bigger pamphlets put at doctor's clinic, where a woman may not have gone for herself, but for somebody in the family, and she sees that. So once she sees it, it makes her begin to think that it might be something which could have happened to her. And so then she talks about it. The thing is, finance is a major issue, because in every rural area, like I mentioned earlier, women's health is last priority. So to spend money on a woman for her treatment, she herself doesn't want to do it, and the men in the house don't care about it. This is the general thing. I'm not talking about everybody doing the same thing, but it is a general attitude, which happens even in the urban areas. It's not like urban areas are all like absolutely, this thing about going. Many families who say that, बहुत दिनों से था, it's been there for about 3 years, but we thought it will get over, and I didn't want to go because my child was having exams, something was happening in the house, there was somebody to get married, so there's always an excuse for that. So in the rural areas particularly, I feel that unless we empower the sarpanch and the asha workers to help these ladies and put a lot of posters around dispensaries and have films which can be shown in the open, so that they are seeing the film along with the men folk in the family, so that inhibition goes away. That will help. And the children in the school, the young girls will not get affected by breast cancer, but if they are taught about it, because
they'll be proactive.
Talk to their mothers, which happens even in the urban areas and villages, definitely, because I know myself, I had gone for a awareness camp, and I was talking to the youngsters, and they said, ma'am, we find the same symptoms in our parents. This was related to tobacco, and they said we have the same symptoms with our parents, but we don't know how to say that. But can you help in saying it? So they were motivated to say it. But in breast cancer, if a girl talks to her mother about it and explains to her, that will be the best thing to do. So I personally feel younger, the asha workers and the sarpanch, because he has the power. And then doing the test and all that in their locality will really help, rather than, insisting for them to come to a center which is far away from their house. They have to miss out on their work, which they are doing either in the fields or otherwise. And that would help.
Right. Mr. Kumar, there are many NGOs, ma'am mentioned ASHA workers. ASHA workers are also doing a lot of work. They're doing awareness on maternal health, infant care, infant nutrition. They're doing so much. So why not do breast cancer awareness as well? Plus, while it is thought, and it is true, that cancer treatment in our country can be very costly, especially if you don't have insurance. We have Dr. Mahanta, Dr. Kishore Singh, who are from public hospitals. Who these organizations give free care, and these are good medicines. They're effective medicines. So how can we get more awareness in the rural areas? That first of all, there is no stigma. Anybody can get it, and seeking treatment it doesn't make you any less of a woman. And the fact that in the right place you could, and with the right means, you could get treatment which will not break your back financially.
Oh, thanks, Anisha. So now, if you look at what ails the system, right? I would say we have a lot of things working very well, but in silos, right? We have several governments and several programs which do screening, right? We have very good tertiary public hospitals for cancer, right? So what's the gap? The gap is what we call the continuum of care, right? What happens after screening? How many of those patients are sent across to a district hospital for confirmatory testing, and how many of them then go on to tertiary hospital for multimodal treatment? And if they initiate, what is the kind of follow-up that happens? Those patients cannot keep going to a tertiary hospital thousands of kilometers away. Is there a way we have maybe improved the capabilities of our secondary district hospitals to do follow-ups, right? I think that's one key part of the link. But I believe the training of ASHA workers is done in several states is something that's on that, and training ASHA workers maybe to do an annual or a frequency of clinical breast examination can help in early detection, which can then later be sent out for confirmatory diagnostics.
Dr. Mahanta, what do you make of the suggestion that, we're working in silos? Now, you can't have a mammography at a village, right? But there can be some kind of screening, and then you go to a district hospital, and then, if it is really advanced, you go to a city. But can there be screening at district hospitals? Because, there are technologies that have come that may not require only a mammography to determine the incidence of cancer. There are new age technologies using artificial intelligence that are coming up, and that may not be very costly too. District centers also have these. Could there be any coordination between bigger hospitals in cities to ensure, which can then perhaps advise district hospitals to have these facilities so that detection happens earlier?
You know what, Anisha? To detect an early breast cancer, we really don't need any rocket science technology. Okay. It can be done very, very simply by a woman herself, by something which we call as self-examination of the breast. So what is more important here? Now, I'd like to just shift it that we have two categories of women who we find suffering from breast cancer. The ones who come from the villages, who usually present very late in the disease because of all the factors that have been enumerated, whether it's ignorance, whether it's the stigma, whether it's illiteracy, whether there's no male member to accompany the lady to the hospital, and general apathy towards a woman's health, especially in the rural areas. And in the urban areas, we have another set of problems where women are driven, women who are educated, who are working, who are empowered, who are driven by, certain goals in their careers, where they are going through a lot of stress and unhealthy lifestyles, because of which we are finding increase of breast cancer. But yes, the better part of it is that in the urban areas, they are detected, at least in some cases, we find them to be coming much earlier than what we are seeing with the rural women. Now, the crux of the matter is that if we can teach all the women in this country to do something as simple as a self-examination of a breast, that itself will help us identifying all the early cases. It is only the high-risk groups, like those who have a family history of breast cancer, or those who are above a certain age, like those who are above 45 or 50, to go for an annual mammography. There are certain risk factors for breast cancer, and in those situations, a woman finds a lump which is, or the ASHA worker finds something which is suspicious, that woman can be taken to the next level. We don't need all women to go through the mammography, the whole gamut. So, they need to know that a small lump, which is painless, is something that needs to be tested further. That's as simple as that. But we are finding women who are coming with, huge breast masses, which are, more than 10 centimeters, fungating, ulcerated. They are absolutely sometimes even with maggots. I mean, it's as bad as that. That means they are hiding this for several months before when it really gets absolutely beyond their control, that's the time then that they are seeking help in the system. Why is this happening? This is simply because we have not sent in this message to that grassroots level. For some reason, it has not reached the grassroots level. So I really don't think, mammography can be kept for selective groups. Yes, it is a recommendation. It is a standard guideline that mammography is a screening tool for early detection of breast cancer. And that can be done for the women who are above a certain age, or those who have a strong family history, where we can, ask them to go for mammography screening at an earlier age also. But generally, it's said above the age of 50, they can go for an annual mammography or a biannual mammography. We don't really need artificial intelligence and those kind of things. In a country like ours, it's very, very simple tools that we just need to teach, whether through the ASHA workers, whether we can target the schools, the colleges, and teach the boys also. Why not the boys? We can teach all the children, or educate them, tell them that these are the things that you need to convey. You teach a child, you're teaching the whole family. So we have to look at these kind of gaps which need to be bridged. And I think that's my take on a country like India, which has too many problems, and we need to find the simplest of solutions to tackle them.
Right. Dr. Singh, when it comes to urban women, what percentage of women are coming to you with early stage cancers? How were they detected? Is the awareness far more in women in urban settings than in rural areas? And do hospitals that are centered in large cities, do they have any role to play in increasing awareness in far-flung areas? Can they do anything at all?
About half of them are fairly early stage, where surgery and chemotherapy can cure most of them. But still, radiation is required in more than about 50% of the cases, and radiation facilities are very limited, especially when it comes to breast conservation therapy. In this private setup are doing better than the government setup. So radiation for breast cancer have a waiting list compared to other diseases, because it is a cumbersome, technically difficult treatment. You have to give a lot of time on the machine also. And second thing is, what was the second part?
I was saying that can the hospitals that treat so many of the cancer patients, whether they're local or coming from far off, can you by any way create awareness that look, don't come so late? Tell people back home that be more proactive.
Once they become aware, and almost all their relative and family become aware. But before that diagnosis, they hardly have think of cancer can affect them. They are busy in their own life. They are struggling with their own day-to-day routines. So program like this should be there to increase the awareness, because eyes see only when you know something. Otherwise, I won't see. If it is not in your brain, eyes won't see it. So increasing awareness is the primary thing, because detection become much easier, because symptoms are very subtle and non-specific. So unless you have high degree of suspicion, you will not going to think of it, and you will not going to seek the opinion for it.
Right. Dr. Prashant, awareness is going to take time. It doesn't happen overnight. It is, a lot of companies are running CSR campaigns. You have ASHA workers being trained. So slowly and steadily, this message will get drilled down. In the interim, how can, there be decentralization of cancer care? Yes, for a complicated case, you will go to the but for still keep going to the city. Can we have better palliative care in a localized fashion? What are your thoughts on this?
Yes, certainly the need for decentralization is there, and there are efforts being made by the Ministry of Health to decentralize some of these care so that patients do not need to travel to the cities for every course of the therapy. But it's a work in progress, and it has its own challenges. Regarding the awareness for seeking, breast cancer will not have a independent awareness or an action. This is overall knit within the societal perspectives of health in such, and women's health. So what kind of priority you give is something which, it's a societal perspective and how society sees it. And the intervention has to be at a societal level. I would say the first intervention is to tell people, and people should understand that it's not the woman's fault that she has developed a cancer. It has nothing to do with womanhood. It has nothing to do with her character or any other attribute. It's something which is beyond her control. Secondly, if you do get some suspicion, please go for medical advice. The problem is that a lot of patients, so that there is a chain. First of all, there is a barrier in getting diagnosed. Then once you are diagnosed, there is a barrier in starting treatment. People go for alternative treatments, or they just think that, something, this is some boil or something, this will go away, apply this thing, that thing, do this, that. that delay in starting cancer-directed treatment is the second barrier. And the third barrier is completion of treatment. So, one has to look at all the three barriers and the awareness has to be for all three. It's just not detection and detection. It is also about completing the continuum of care. It is also about, so continuum of care is not only the provider's responsibility. Continuum of care also lies with the patient to see that you follow the continuum of care, and patient will keep switching between public and private sector also. So, decentralization has to happen in totality. It cannot happen in silos.
Right. Mr. Kumar, the points that are being raised by Dr. Prashant are quite pertinent. Both public and private sector will have to do this, and sensitize the patient to the fact that, this has to be a proper journey, and whatever barriers you face at whatever point have to be overcome. So, in your experience, how enthusiastic is the private sector to do this as well? The government has public hospitals in cities. They are helping now with setting up district level and tertiary level facilities as well. When people are willing to pay for all of this in big cities, could we have some tertiary setups from private companies as well in smaller areas so that it becomes, the number of people being treated can increase?
So I believe the ability to pay for treatments is just one of the factors, right? Now with the rollout of Ayushman Bharat or PMJY, right, even the poorest of the population is able to access treatments, right? May not be the latest treatments, but at least the chemotherapy, radiotherapy, and any other hormonal therapies that they need, right? What this would help is that it will bring in investments from the private sector to set up treatment centers closer to the patient. What is currently underserved, right? Because private sector may not want to get into a market which is already crowded, the urban markets. But then there is a clear need in rural areas where the buying capacity is coming up because of government interventions. This can lead to further investment to build it up. And just linking up to some of the earlier points that we discussed as a panel, right, which is on awareness, right? One thing that I ask myself is, how many villages in India have never seen a cola, right? Cola is available everywhere.
Yes.
The awareness is so high, right? We have, as a country, we have also been able to build awareness and action on such public health issues. Like one example where India succeeded, I would say, is polio eradication, right? Now, for us, how do we build the need for breast cancer to also take that limelight, the importance level, right? Because as some of the panelists, especially was Vandana Gupta, who deals so much with patients, talked about, the patient over here is someone, a middle-aged woman, who is the anchor of the family, right? You're talking about someone, a 35, 40-year-old running the family, who is having children in school, managing everything, right? So that's a critical stakeholder for the Indian society. So it's for us as a society also to increase the awareness and get it up and make use of government interventions to build the infrastructure with partnership with both public and private sector to build a continuum of care in terms of awareness, diagnosis, and treatment.
Right. Vandana ma'am, what do you must be getting a lot of calls, a lot of people reach out to you. How important do you think is counseling? And, Mr. Kumar is saying, if you could create so much awareness about polio, what stops you from doing this from breast cancer? Who does the onus lie on when it comes to this? Because in the end, it affects the entire society. But who's going to take the lead here?
See, according to me, polio is for children. And every child, rich or poor, is equally important, right? So even a woman in the village wants to make sure that the child is safe. Yes. So polio drops, and it has been a campaign which has been taken up in a very big way by Rotary Club. And, so it has really reached out to each and every household and also the government. Now, as far as breast cancer is concerned, it concerns a small segment of the society, 50% of our population, if we were to say. So what is the seriousness about it? How many people are talking? How many posters have you seen about how to do breast self-examination in any clinic that you have visited? Suppose, for example, you've gone to 10 clinics, even in the urban areas. How many clinics have that poster? So almost none.
None.
And so to expect that that type of poster would be in a village or in a rural setting, I'm not sure. So, what the awareness that we are creating, the organizations are creating, the NGOs are creating is a very limited awareness. We go and talk about it, we tell them what to do and period. How many people are really doing the follow-up? How many people are ensuring that the right facilities are available for the checkups and all that? That is important. Just talking is not important. Important is to create that infrastructure that it is at their convenience that their checkup can be done, and also onus also lies on the NGOs or whoever is doing the awareness that even if one person is detected with breast cancer, the entire treatment should be taken care of. Today, people are not even coming for the checkups because they feel, abhi to we don't know that we have cancer. But if we come to know, then we'll have a sword hanging on our head forever. But if we can assure them that, your complete treatment will be taken care of, the numbers will increase. The number of people coming will increase. So awareness is not only telling them about the disease, it is also, hand-holding for saying that your treatment will be done. It's also like, we have so many regional cancer centers across the country. And if each regional cancer is equally equipped, because for somebody like, for example, living in, say, Satara and diagnosed with breast cancer has to come to Mumbai and stay here for treatment. Imagine the expenses, imagine the inconvenience, the travel, the looking for a place to stay in Mumbai and all that. But if there's a regional center near that area and the person can go there, it would become so much easier. So what we like, Dr. Prashant mentioned that there are many barriers, and these barriers are at every stage. At the stage of diagnosis, at the stage of encouraging them to come in for their treatment, at the stage of ensuring that their treatment is done at this stage, and there has to be constant counseling all through. So that is how it helps. It can become a movement like polio, if we were to give as much importance. I mean, just now, the hot topic is the Hathras girl and murder. So you can imagine the value of a woman. So that is why a polio-like campaign is not being done, and it is not naturally not effective.
Right. Dr. Singh, ma'am is saying that, just telling women that, this is how you do self-examination and this is how you can prevent yourself, you can know that and catch it early on is not enough. I mean, just the fact, knowing that I have cancer isn't going to make me run to a hospital. So who's going to do this? Who's going to say that I'm going to be a backstop? I'm going to ensure that if because you found out that you have a problem, we will get it diagnosed properly and treated properly. Because, estimates are saying that, cancer in our country is going to increase. We have a young population now, but 10 years later, that's not going to be the case. We're going to have more and more cancer patients coming in. So, to say that just the government is going to do this, how far will we reach there? The private hospitals know that, there is a demand for this. What can they do to give this assurance to people? So that they feel okay about, taking the treatment, that they will be treated. Just diagnosing is not the end of the story.
Breast cancer is a little bit unique in this respect. It takes time from becoming non-palpable to palpable disease, and from palpable to become locally advanced. Again, it takes time. So it gives lot of time to give you diagnose and lot of time to give treatment. And good thing is, it is curable if you treat and give proper treatment in the early stage before it go beyond the local disease. Local disease can be treated very easily and cured easily by surgery and simple chemotherapy, which is available and affordable at most centers. Problem comes when it becomes locally advanced and it requires radiation therapy and long cycles of chemotherapy. which are not available, and some of the drugs are costly also. So to give confidence to a woman that you can seek opinion whenever you feel pain in the breast or any heaviness or thickening of skin or lump in the breast, go immediately to the surgeon. It may be cancer and may not be cancer in most of the cases, because cancer is not that common compared to other benign breast diseases and other non-cancerous diseases. So seeking opinion on having non-specific symptom is very important, because fear of cancer is there, and because of this they do not take the opinion. And further, they also fear that if they are diagnosed with, then it is a long haul for the treatment, including the cost and moving away to a higher center. So giving the confidence that it is curable if diagnosed early, and it is treatable, and it gives you long life, even if it is not going to get it cured. So
Right.
this confidence has to come.
Right. Dr. Mathur, you have enumerated for us the barriers that come at different stages, for diagnosis and treatment of breast cancer. What are your ideas so that some of these barriers at every level can be removed? Vandana ma'am is talking about creating awareness. Mr. Kumar said create awareness. Vandana ma'am said just awareness is not enough. Give an assurance that if you find out there's something wrong, you'll be treated quickly, and somebody will help you there. The cost won't break your back. So, how do you think that all the barriers you enumerated can be progressively handled and removed?
Yeah, each barrier has barriers within themselves, and women's health is primarily a decision-making capacity. It's an empowerment of women in totality. If you look at the available published screening programs or screening literature, the dropout from screening to confirmation of diagnosis is almost 50%. So even if you screen and you suspect, the lady does not go for confirmation, and that decision is family decision. It involves the husband, the males in the family, the mother-in-law, and many other determinants. The fear that cancer is a death notification. So that fear itself doesn't allow them to move to the next step. Even that suspicion, the confidence that there are other home remedies and other alternative systems which will take care of these of this illness kind of a thing, doesn't allow them to move forward. Besides economic reasons, and the children going to school, who will look out after the house, and so each visit to a distant place for confirmation of diagnosis itself. But the primary root cause is women empowerment, and that happens in totality. Today we are talking about breast, tomorrow we can talk about cervix, we can talk about lung cancer, or even we've talked about polio. Polio has been a great success story of social mobilization which happened, and that is how the country learned about social mobilization. And I was fortunate to be part of that movement in the earlier days. So I learned a lot from that program about social mobilization. The other is availability of good, reliable diagnostic facilities nearby, so that even if there are not diagnostic facilities, there can be systems which take samples and carry them. So the patient need not physically travel 500, 700 kilometers to get the diagnosis done. The counseling is an important aspect, and for which I think the health systems, or in public and private setups which are there in the local areas, need to take up that responsibility. It also entails a lot of education of the health professionals, including the doctors, because everybody is not a trained oncologist. So that perspective about sometimes healthcare is also delayed because of wrong or inaccurate referrals. That is another big problem which is there. There is a reasonable economic areas
Dr.
and all who do that kind, and NGOs and civil society is doing a great job in that respect, and they need to be strengthened further. So they need to handhold these patients. There has to be a lot of education, and there is this fear that either cancer will kill you or the treatment will disable you. This has to be tackled at very aggressively, that neither can kill you if it is done at the right time, at the right place, opportunity, and you complete the treatment. The biggest thing is you should complete the treatment. Any lady in the house, any woman who sees that there is a family history of breast cancer, the mother had breast cancer or an aunt has breast cancer, should be on a high alert for any history of ovarian cancer, because these are genetically linked cancer. So that kind of awareness should be there. In totality, it has to be seen.
All right. Dr. Mahanta, in your experience, when women have come to you and sought treatment for breast cancer, how many of them have, expressed this fear that they will not survive the treatment? And, have you been able to pick up that, these are some of the reasons why they have come late for treatment?
Yeah. I get a varied kind of patients, and if you ask about the age range, my youngest patient, she was an 18-year-old girl, and she's now doing perfectly fine after completing her treatment. And I have treated patients up to 85 years old too. So, and a lot depends on the stage in which they come in. And yes, I have had patients who break down in my outpatient department, and who have, who cannot control their emotions, and who literally, cry saying that, they don't want to die. They have the family, they have the children are very small. Most of these women, I find, are the ones who are between, 40 to 55 years, who have children who are still in school or, young, not yet settled. And they have this fear. They are not even aware of their stage, what stage they are in. They might be a curative, completely curative intent of treatment if they are early stage, but just the word cancer itself is enough to make them feel that, it's like a death sentence for them. So I have realized that it's very important to have, counsel them really well, explain to their family members about the entire treatment course. Actually, the treatment of breast cancer, as we see, it's a very long haul, starting from surgery. Maybe there might be chemotherapy before the surgery or after the surgery, radiation, and sometimes the chemotherapy can go on for a year or even more. So it is an extremely long haul, and we try to ensure that every patient who gets the treatment at least completes the treatment, because that is what is expected in a multimodality tertiary cancer care setup, that we do not have defaulters, we do not have dropouts. We want all our patients to complete their treatment. So in the curative setting, when we explain to them very well that this is the stage of their disease and this is the treatment that we are going to follow, and if the patient comes on time and takes the treatment on time, whether it's chemo or the radiation or the surgery, then in all probability we'll be able to eradicate the disease completely and she can have a normal life. And that brings a huge sense of relief to the woman and her family members. The problem arises with the ones who come in the advanced stage, and that's the majority. As of now, we are seeing, say, close to 60% of our patients, 65% of our patients come in pretty advanced diseases, and those are the challenging groups because we can't be actually, giving them a false sense of hope. At the same time, we cannot even, be really blunt with them. We'll have to explain it in such a way that it's very important to take whatever treatment options are available for them, because sometimes even if they are having a bone metastasis, it's a stage 4 disease, but it only has a metastasis in the bone, and they might be candidates for hormone treatment. So we have, if these patients continue their treatment, even if it is stage 4, they do have a good progression-free survival, as we call it. That means the disease may not progress for some time if they continue their treatment properly. So these kind of reassurances to be given to the patient is extremely important. And as and when possible, we try to incorporate or bring in the, especially when we are treating seeing the advanced disease patients, and the palliative team actually comes in along with us. And in this way, we try to group counsel the patient and see that the best quality of life is ensured to the patient. So our main aim is to see that we are giving them the best quality of life. And if we can give them a curative treatment and the treatment can be completed, we ensure that they have a good follow-up so that we can really track them and see that the way they are doing. So these challenges, yes, we do have, I think I encounter at least 2 or 3 patients breaking down in my OPD on an average. So, that's I think, it's very difficult to get a strong woman who feels that, she can fight it. But yes, when we reassure them, we have good fighters, and we have some women who have really been exemplary examples for others too. They have been inspiration for others.
Right. Dr. Kumar, if you, in your experience, Dr. Singh, I wanted to ask you, ma'am has said that she sees patients breaking down, they fear for their lives, but if they are sure that the treatment will work in whatever stage they are in, patients continue with the treatment. But if a patient has to, like breast cancer can be a long-term treatment. So if they are far from their homes, how will they be able to complete their courses? Could there be a solution there?
First thing we ask before starting treatment is, do you have a place to stay in Delhi or not? That is the most important thing. Otherwise, it is impossible to complete the treatment, which runs more than 6 months at least. But we do provide them concessions for traveling, because patient can travel in train or any other mode and can take the treatment for staying just 1 or 2 days in Delhi. So it is a problem. And often because of this, patient do default on the treatment, especially those who are coming from the far off. But in future, this may change with the government of India planning to start the chemotherapy drugs treatment at district hospital. In future, we may see a decentralization of chemotherapy at least.
So that will definitely be a big relief for patients who want to keep up with their treatment, right? And after your surgery, in the initial cycles of chemotherapy, it can be continued closer to home. It will become much easier for them. Mr. Kumar, can the private companies also help in this initiative so that some of the treatment moves to the tertiary centers, to the district level hospitals, and cancer care gets more decentralized?
Sure. So we are aware of some projects and some states where some kind of work is happening on it, right? We know places like Madhya Pradesh, Rajasthan, where some things of these have been pioneered by some of the HCPs and centers, right? For private partnership, Novartis is also supporting a project by a NGO, Japaico, in the state of Orissa for a pilot on building continuum of care, where we are trying to bridge the gap between awareness, diagnosis, treatment, and follow-up. Right? So it's right now in pilot stage, but I believe there's a lot of interest in that, because at the end of the day, private sector is also an integral part of the healthcare ecosystem, right? And we also, both the public as well as private, as well as various stakeholders, will need to do their bit to improve the overall health system, so that at the end of the day, patient outcomes is what is most critical. And until we improve that, each player will have to keep working on that.
So, Mr. Kumar, can you tell us how this pilot project is working in Odisha, so that perhaps more people will get ideas on how things can really work?
Okay, so basically, Japaico is an NGO that's focused on women health, and they've also now increased the focus on breast cancer. We are doing a pilot with them for 2 districts in Odisha, where they are building awareness material for general public, as well as training programs for ASHA workers, where they're going to train the ASHA workers to conduct clinical breast examination. And once there is a positive case or suspected case. They're also building up capacity at the public, the PHC, the primary health center, to have a more detailed examination by a trained medic, and to further send it up to the district hospital. So basically, they've identified a couple of district hospitals and tied up with the tertiary hospital in Bhubaneswar for getting the patient referred for that. So we have not yet reached the stage where the patient has reached the tertiary hospital, but still working on the screening part. So once we are able to build and establish a continuum of care, I believe that's a pilot with a success we can be able to replicate in multiple locations across the country.
Right. Vandana ma'am, Mr. Kumar has told us about a pilot project working in Odisha where ASHA workers are being trained to explain about breast examination, perhaps even conduct one, and then follow it up further should there be a suspected case. Now, you said that why the polio campaign worked was because it involved children, and children are very important. But women are also important. They're half the population of this country. So for the social mobilization to happen, and there's all these steps of training the ASHA workers, or decentralizing the treatment facilities, they can also happen. But what will it take for this to become a social movement? Creating the awareness and removing the stigma.
Okay, from my point of view, this entire thing is a social problem, starting from the men who should understand the value of their women, and so they should be able to, understand, encourage them for their treatment and all that. But more than that, I've noticed in the rural areas and in the women in that area that whenever they are going to have a child and they get these cards and they're supposed to go for their checkups on a regular basis. So maybe during that time, it can be built up that, when they've reached the age of say 35 or 40 years, after that, to come on a regular basis for a breast self-examination. And at that time, they can be taught about breast self-examination. So just as they go regularly during childbirth, the same way they go every 1 year or 2 years after they've learned it and all that. And if they find anything suspicious, it's not like something which has come as a shock. It is something which they've been working on from the age of 35 or 40 years. And then, the card can be maintained, the details can be put over here, there. So everybody becomes a party to the entire process. The men in the house, the women in the house, so it doesn't become like, it's cancer. Nobody calls it as a shock. It's a natural process because I think each woman can have cancer, have breast cancer. So it's not like something which is coming from outside, or the stigma will also die because of that. So if that can be inculcated in our medical programs, I think that will be a big help. So then it will be as successful as a polio program in creating the awareness.
So you're saying, ma'am, that a medical card is maintained at the village or the district level, where women report every year on the status that they have done on their breast examinations.
Yeah, I'm not talking about every year. So after when women to have breast cancer, if at all, so they start learning breast self-examination at that time. And then they do that and they go and report after 1 year if they find anything unusual. If they don't find anything unusual, even then they need to go and report, so that we know that it is going to be caught early if they've been doing it meticulously and religiously. So that way maybe we can help in bringing down the percentage, just on the late this thing that is happening diagnosis. It may come in a very early stage, and that would be helpful.
But ma'am, I'm just taking the idea that you've given. I'm a new mother. I'm in my 20s. And you're telling me, this is how you do breast exams. So you do breast exams once you turn 35. Or you start doing it, but start reporting it once you turn 35.
No, I'm not telling you to do it when you are 25 and a new mother. I'm saying you're a 25-year-old woman and a new mother. All the best to you. Have fun. Enjoy your child. After the age of 35, we want you to come to the clinic for a checkup. I'm not even saying breast self-examination. I'm saying you come for a checkup. When you come for that checkup, at that time, I make you aware about the breast self-examination. And I tell you to follow 35 or 40. And I tell you to follow it meticulously and come every year and let me know. And at that time, I can also be shown the different type of things that I may find in my breast. It could be a fibroid, it could be, like a breast cancer lump, it could be something else. And so when I come the next year, I come to the doctor again with my checkup to see. And maybe the infrastructure can be built in such a way, maybe we need a lot of resources for that, that somebody calls them after 1 year. The records are maintained. They may not be able to go on the computers to have the records, but now everything is getting digitalized, especially now when COVID has come in, we know that everything is available on the computers. So those records can be maintained on computers, and people can be made responsible to follow up with them to see, why they haven't come. And if they've come, they come and show themselves. So I'm just thinking aloud of what can be done to make it easier and to get people in the early stages of the disease, and also not have the fear of cancer. So it's a checkup that you're going for. And then if something comes up, then we talk about cancer. Otherwise, we don't talk about cancer. When you are a new mother, we talk about only happiness at that time.
Yes. Mr. Kumar, this sounds like a good idea, but somehow I feel that if you left it on the woman to do it, she's just going to shirk it off and say, yaar, हजार काम है, बच्चों को देखना है, घर को देखना है. They're most probably going to forget about this. So we need somebody to remind them. How effective is this going to be in your mind? And should that somebody who's reminding them also be part of their family? Should the family also check with them? The doctor said that, every year you go for the checkup. Did you go? Can this work? How can we get to this level of awareness? And training, of course. If there will be workers who will be keeping your records on an annual basis to see, whether you did the exam, if you found something unusual or not. Can this be done in your mind?
Okay, so maybe I would like to highlight two of the things. One which Dr. Mathur said, under which Vandana Gupta said. Right? Dr. Mathur said that breast cancer needs to be also looked in from the overall woman health perspective. Right? And Ms. Vandana Gupta said that woman is an integral part, but no one takes care of her. Right? And the men need to take care. That's what specifically that she mentioned. Right? Now, and hence, for us as a country to improve on this, the social messaging should be targeted to the men and the family, right? If you see the latest menstrual health program by the government, which has a Bollywood star in it, it's targeted at men, building awareness among them, right? And I think that's critical thing. It's not a problem just by women, but it must be highlighted as a problem in society. And hence, the family should also take care of it, and to ensure that the woman or the family are getting tested and going for appropriate treatments, right? That's from the breast cancer. But on the whole, as a society, we are not a very health-seeking society. There are countries where people, they call them a pill-popping population, right? 2 pills in the morning, 2 pills in the night, I'm very healthy. But for us, if I'm feeling unwell, I say, okay, let me take a day's rest. Try some natural remedies. Then go in for medication. That we put away treatment for a long period of time, which may not necessarily be very good in the long term. And these are some of the social changes that needs to come up. One, specifically on bringing women to the center of the health, families and men as a critical component. And second is increasing the health-seeking behavior and awareness for the population as a whole.
Right, but Dr. Mathur, would that change come about in people that if you have a problem, seek treatment, even for women and their healthcare issues? Because the reason perhaps they don't seek out treatment is because they're fearful of the cost, they're fearful of the treatment time. How do we make people seek treatment at the right time?
Yeah, so the general malady is health-seeking behavior, and this has a lot to do with the psyche of the Indian society, that women get the last piece of everything, even starting from food itself. Now, we are talking of a society where women's health is neglected, and there are a lot of issues regarding that, whether it is due to family issues, whether it is because of the priority issues, and then women themselves, I'm sure the clinicians on this panel, half of the women who break down are not crying for their own illness. They are crying because who will look after the children, what will happen to the house. and what will be the social implications of this. And so they're worried not about the cancer they have, but they're worried about many other things. And that is what breaks them down. And they are very resilient, they have a tendency to hide, they have a tendency to bear the pain and the misery which goes along that way. So I think we need to, first of all, if you go to any women and say that, we want to check you for cancer, that itself is a deterrent. So this has to be part of a breast care program. And this has to start right from early age. Even when women, so as Dr. Singh said, cancer is a very tiny fraction of breast problems. There are a lot of non-cancerous issues which happen. I mean, we don't discuss things like how many women undergo breast surgery or abscess removal, post-lactation period, and all those kind of issues are there. So it's about a breast care program. We must also not miss opportunities. So any woman who is in the high risk category, and who is in the high risk category? Anybody above the age of 40, anybody who has some risk factors. So now let us look at women's health from a risk factor perspective. What drives breast cancer? Okay, so obesity, physical inactivity, unhealthy diet, alcohol consumption, tobacco consumption. These are some of the known factors. And if you look at the statistics, women are not behind in all these. Indian women are more obese than men because they don't do physical activity. They don't do a lot of other things. They don't eat proper diet. So this has to be weaved into that. And whenever there is a health contact, whenever a woman for any reason contacts the health system, whether in public or in private sector, if you are in the high risk category, that means you are above age of 40, you have a family history of breast cancer. First of all, it should be elicited by the doctor. So even professional training is required. And if you have any of these high risk flags of risk factors, you should be assessed for breast cancer also. You could ask them to do a self breast examination within while they are at the clinic, or the doctor or the nurse does the breast examination, and this should be repeated. So we should not lose out. So we should not have a silo vertical program that you just gun around women with breast cancer. It's part of a total package and linked to many other things. Menstrual health is there, menstrual hygiene is there, women other issues are also there, and this has to be built in there. Then only this will come up in a much better way. And it's not that this is a problem of rural or small city. Even the urban centers are not doing pretty well on these factors. So even if you are sitting next to a hospital, you may still not go to that hospital to get the treatment. So that barrier itself is huge, which will need to be overcome. And that has to be done as an overall package and not as a vertical gun trotting.
Just to treat breast cancer. So, Dr. Singh, I want to come to you. Now, Dr. Mathur is also saying that, there has to be training of some of the doctors as well. And in our country, the number of oncologists in any case is not too much. Now, even when I go to meet my doctor will ask, how many children? When was the pregnancy done? Any more issues? She never asked me if my mother or my child or anyone in my family has had breast cancer. She never offers to do a breast examination for me. Neither does she ask me if I've done it myself. So, do you think if these become part of your regular checkups, if medical professionals are also sensitized to keep this in the back of their mind when they meet their patients, will it help create awareness?
Every family has one or other cancer patient nowadays, or they are aware of the one of the. But fear psychosis is so much they don't want to think what to tell you about talk about the cancer. They don't want to even think because of this fear psychosis, and they think that this is affecting the other. This is not going to come to their own way. So fear psychosis has to overcome And so much so that even in MBBS, cancer is not a mandatory subject. So our training has to start from the MBBS itself, which has cancer is not regularly taught to them. And once they come to post-graduation, they become so focused in their specialty that cancer become sidelined. And the development in cancer are so fast, and it has become so vast and sophisticated. You need a full-time person, which is not readily available in district hospital or even medical college without oncology. So this situation is going to change. Government is doing a lot. It is opening tertiary care center. It is already opened lot of regional cancer center. Then state cancer institute. Even private center is coming up. Even Delhi itself has more than 36 private cancer centers. So situation is going to change. Treatment going to become more affordable, more accessible. Then this from hopeless and despairiness from the word of cancer will change to something that it is curable.
But Dr. Singh, my question is that, why are we leaving this to the specialist? Dr. Mathur said कि अगर आपने breast cancer awareness campaign चलाना है तो वो आप वैसे लोगों को डरा दोगे. When I'm going to meet my gynecologist, she needs to be a specialist in oncology, right? But she can just ask, have you done a breast exam? Or can I do it for you? But they don't ask. Why?
Government of India has already started included this early screening program, which has gone to the district level hospital. People have been trained, and it is going to come into regular checkup in future. So work is going on, and cancer with cure, you can see all around yourself. So they will going to be torchbearer that cancer is curable if you can get it treated properly and get it diagnosed. So fear of cancer will gradually go away as the facility become available and as we increase the early cancer detection.
Right. Dr. Mahanta, Sir is saying that the government is increasing investments into tertiary care, and soon you'll be able to get perhaps chemotherapy sessions closer to home, etc. But what about palliative care and treating people? If you're going to get admitted into a hospital for the long term, the cost will be a lot. Could you have better palliative care which can have a follow-up closer to your home itself? And what kind of training is required here?
Yeah, palliative care is a totally different ballgame altogether because it deals with cancers which are already advanced in the advanced stages and where you have very limited options of treatment now. And it's very important or pertinent to give this kind of treatment as closer to home as possible. So basically, palliative care can be given in 3 settings. Firstly is in the hospital. The second could be what we call as a hospice, and the third is at home. So we need to steer the care that can be given in a palliative setup in whatever suits the patient. So the palliative care team needs to identify whether this patient will be best cared for. Do we need to admit this patient temporarily in the hospital? And then, when we treat the acute problem after, the patient is a little stable, we can send the patient home and advise them to contact the nearest palliative care services nearer to their home. So in Assam, what we are doing, we are having some palliative care programs which we are conducting twice a year. And this is basically for doctors, nurses, and even paramedics. So basically, we are focusing on the doctors and nurses. So once we have a patient who has come to our palliative care setting, we try to ensure that this patient can get his palliative care somewhere nearer to the home. So we have somebody who's already trained up, and we can tell the patient that this is the person that you would need to contact once you are at your home. And we also explain to the family member the importance of keeping the patient at home during this period of time, because time is kind of limited. It's important for the patient to be now closer to his near and dear ones and to be more in a more comfortable setting rather than to be in a hospital setting, because we are dealing with a potentially irreversible situation. We are not going to revert this patient back to normal. So that's at home. And the third scenario, that is the hospice. So we do have, in fact, there is an NGO which runs a hospice which is very nearer to Guwahati. And we do have a very good referral system for those patients who do not have caregivers in their home settings. So if somebody does not have the essential caregiving facilities in their own homes, then they can opt for the hospice setting where everything is taken care of and the patient as well as one attendant can stay in that palliative care setup, and all the needs, the basic needs that are required, especially like care of pain and cancer pain, which is the most prominent or the most important component of the palliative care, along with other supportive measures, can be given in the hospice. So it's very, I think we need many more such centers to come up in and around so that patients can be referred appropriately to these centers. We don't really need to burden hospitals with the palliative patients. That is most important. Hospitals should be reserved for more of the curative intent patients where we are giving them, chemo or the surgery or, something where we can revert the patient back to normal. So
Right.
That's,
Right. So I'm going to take closing remarks from each of you. Let me start with you, Dr. Prashant. The one best idea you think that can be done now to increase the awareness and get women to come for treatment early on?
Yeah, as I said, that this has to be part of a whole women's health initiative, and this should be built on that. There should be a lot of opportunistic screening and testing being done. Testing, I mean the self-breast or the clinical assisted breast examination. There should be reassurance that this is something which is curable if detected early, and if you have been detected, please complete treatment. It will be cured and you can resume a normal life.
Right. Dr. Singh, your best idea to get women to be more proactive about their health?
Them young and use lot of opportunity screening and awareness when they come to hospital, like putting the slogans on hospital prescription, etc. Make the special campaigns or months like this one more prominent in the social media or in the hospital itself.
Right. Mr. Kumar, your best idea to get people to talk about breast cancer and catch it early, not just women, but everybody, the society itself.
Sorry. I think we need to remove the fear in breast cancer, right? It's like there are several cancers where you can live with it. The therapies are advanced to the extent. The same is happening in breast cancer. There's a significant advance in therapies. So there can be a time when you can live with breast cancer the way you're living with diabetes.
Okay.
For getting that done, you need to have early detection, appropriate treatments. I think that's one of the critical things.
Okay, getting the fear out is very important. Dr. Mahanta, your biggest idea or takeaway to get more awareness about breast cancer?
Yeah, the first and foremost I would say is bring up the conversation. So in the rural areas, talk to the people, talk to the panchayat groups, talk to the women's group, the self-help groups, send the ASHA workers to the doorsteps of the women, make them talk because they are the ones who are, who come to the closest contact and they are women themselves. So that can bring a rapport in the rural setup. In the urban areas, seek volunteers to start talking to in the schools and in the colleges where especially in the to all forums, because that's where you get a large conglomeration, and so that message can be spread to the homes. And in the hospital setups or in the healthcare setups, we can have opportunistic screening. So one is the community screening program and the other is the opportunistic screening program when they come to the hospitals. So for that, we need to have the campaigns so that when a woman comes to a hospital for any other reason, that's the best time to catch her, to also have her screened for breast cancer, or at least, get her a clinical examination done. And of course, spreading the news much more widely. I don't think just 1 month in a year is enough. We need to talk about this throughout the year. Talk about it more in through television, through social media. I think television, just like the polio campaign, which was almost like a household thing. Everybody gets to know about it at least 3 times a day. So bring it out in the media. Send the information to the bedrooms so that men, women, and the children, everybody knows about it. We should not shy away from this. We will be doing a long thing. Yes.
Right. Ms. Gupta, your best idea to increase the awareness about breast cancer?
Okay, I must share with you that I am a cancer survivor myself. So, being a cancer survivor, I know that when I talk to a patient about cancer and about survivorship, it adds a lot of meaning. So, everything else has been covered by the other panelists. So, I would like to add on that we have such a large force of people who have recovered from breast cancer. If we can have them or their stories published as much as possible or made into videos, because in the villages many people may not like to read, but they may like to see a movie, of a person who's talking, and it's a live person, especially treated in India and is now doing well. And or if this force can get together or can be put together and be sent out, like you are saying you're doing something in Orissa. So if there are women in Orissa who are breast cancer survivors, and they can go and talk to the women, share their stories with them, that will be the most positive thing to do. So besides all the other points that we've discussed, I think having survivors share their experiences either in form of movies, documentaries, or in form of conversation would help a lot.
Surely that is extremely inspiring to hear survivors who've lived the tale to tell everybody else that you can do it too. Thank you everybody for joining us today and sharing with us your thoughts on breast cancer, on the differences that you see in your daily life in between the different settings in rural and urban areas, and all your ideas on how we can increase awareness to see and ensure that there is early detection and hence early treatment that will help stamp out breast cancer or at least increase the survival rate of breast cancer in our country. Thank you so much for joining us today.
Thank you, everyone.
Thank you.
Thank you very much.
Thank you to everyone for tuning in and watching this show. Do remember, we'll be back on Monday. We are not letting go of this. We'll keep discussing all various aspects related to breast cancer. So come back again on Monday for another show where we will be speaking with experts, and this show was supported by Novartis. We want to thank them for that, and of course, we'll see you again on Monday. Goodbye.
Thanks a lot.